So, good afternoon, all. Today, my topic of presentation is diabetic retinopathy changes seen in ultra-wide-field fundus imaging after anti-VEGF therapy. Diabetic retinopathy, leading cause of visual impairment in the world. It is the most common cause of microangiopathy of retinal vasculature. As we all know, microangiopathy is the hallmark of diabetic retinopathy, which causes microvascular leakage and capillary occlusion, result in the hypoxia of the retina and release of VEGF. The VEGF is a potent stimulator of angiogenesis and neovascularization. Even though anti-VEGF is the mainstay of treatment for diabetic macular edema, background retinal changes response to the anti-VEGF are seldom assessed. The image here, we can see the comparison of the image visual field. In this is a field that has been taken from the conventional fundus picture, which involves a 50 to 55 degree of the field, but in ultra wide field it takes about 200 degree of the field. More than 50 degrees called as wide field and more than 100 is called as ultra wide field. This is a picture showing an ultra wide field 200 degree image with an overlay of ETDRS 7 standard field and the peripheral field. Here we can see that there is ETDRS 7 standard field, and outside the ETDR is called as peripheral field from 4 to 6, which is involving the five fields. So the ultra-wide field images identify the peripheral diabetic retinopathy lesions that are not visualized using the 7 standard ETDRS photograph, which only captures 90 degree of the retina. Hence, immaculate characterization of the presence and distribution of the diabetic retinopathy lesion across almost all of the retina is possible. My aim and objective are to determine the treatment response of diabetic retinopathy defining and grading lesion in background retina following multiple anti-VEGF injections, and to look for diabetic retinopathy changes within the standard ETDRS field and peripheral field outside the ETDRS field using ultra-wide field imaging. Materials and methods, it's a hospital-based prospective observational study done in 47 eyes of 32 patients based on the Silva PS et al. And the subjects are patients present with the diabetic retinopathy who was advised for anti-VEGF injection for the treatment purpose for macular edema. It's conducted in tertiary eye care center in South India for the duration of 6 months. Inclusion criteria: all cases of diabetic retinopathy age above 18 years who receive intravitreal anti-VEGF injection for the treatment purpose. Exclusion criteria is the presence of any ocular disease like glaucoma, previous trauma, or any other retinal diseases other than diabetic retinopathy, myopic refractive error more than 6 diopter, eye media opacity, eye previously treated with intravitreal steroids or panaretinal photocoagulation, and any recent intraocular surgery within 3 months. Methodology: consent is being taken from the patient, and after a detailed medical history, slit lamp examination and indirect ophthalmoscopy examination is done. A sequential ultra-wide field fundus photographs are taken. The first photographs are taken treatment naive patient, and the second photograph are taken 1 month after the first dose, and the third photograph are taken 1 month after the second dose. The total of 3 photographs are taken for a single patient. The grading of the diabetic retinopathy is based on using ETDRS classification. These are the lesions that has been studied. In this hemorrhages microaneurysm has been quantitatively calculated by using markers. Other lesions has been calculated by whether the lesions is present or absent. Hard exudates is quantified based on the picture given below. This is the ETDRS grid, and the number of grids that is involved is being calculated, and the significance is measured. Coming to the result and discussion, majority of the patients have been age group in 51 to 60 years, and majority of the patients are diagnosed as moderate NPDR. The effectiveness of treatment, it was found that the lesions like hemorrhages, cotton wool spot, microaneurysm, and hard exudates are clinically significant with a p-value of less than 0.1, but rest of the lesions was not clinically significant. Distribution of the retinal lesion in the wide field images. Most of the lesions has been distributed within the ETDRS field. Majority of the lesion. In the picture table below, hard exudates majority, that is 89.3% are seen in the ETDRS field, and only 17.2 are seen outside the field. The effectiveness of treatment, the treatment was of the severity of the diabetic retinopathy was significant. This is one of the patient image before the anti-VEGF injection. Here you can see numerous hemorrhages, and this is after the dose. The hemorrhages have subsided. There was a statistically significant association noticed between the central macular thickness and a p-value. And coming to other treatments, other comparison with other studies, DCR.net protocol S suggests that ranibizumab was not inferior to PRP for the treatment for PDR. Silva PS et al. Study show that only 1/3 of the lesions were detected on ultra-wide field imaging. And DCR protocol W trial showed that over 2 years, aflibercept reduced the risk of development of vision-threatening complications in severe NPDR. And Sophie Burnett et al. Conclusion and recommendations. Conclusions of the study was hemorrhages, microaneurysms are being significantly reduced. Ultra-wide field image show that there is considerable amount of lesions outside the TDRS field, and the macular edema significantly reduced. Recommendation: there should be large sample size, long-term follow-up, and there should be a software for the analysis. And these are my references.
Questions for you.
Yes, sir.
The first question you mentioned about anti-VEGF. So,
Yes, sir.
the anti-VEGF that we use.
Sir, majority it was Avastin was used.
Mentioned in your study.
No, sir. Actually, it was not.
Okay. The second thing is you use this wide angle. So the things that you mentioned, the list that you mentioned, that you can pick it up in your 20D and 90D also, right? So what is the additional information that you're getting from this gadget that you use?
So this is a non-vidriatic this one, and also there is a fast acquisition of images, and also we can store the data and can be transferred. And also these can be sequential fundus imaging, but the treatment response can be assessed using the ultra-wide field images.
In this particular gadget, you not looked at macular edema, is it?
No, sir, we cannot do. If it is associated with wide field fluorescent angiogram, then we can assess, but at present it is not.
I call upon the next presenter, Dr. Atulya CP.
Good afternoon all. My topic for presentation is comparison of efficacy between innovator ranibizumab, aflibercept and biosimilar ranibizumab in patients with wet age-related macular degeneration. So age-related macular degeneration is the leading cause of irreversible central vision loss in older individuals. Presence of choroidal neovascularization defines the wet ARMD. Here a protein called VEGF makes abnormal proliferation of the choriocapillaries, which will break through the Bruch membrane and reach the sub-RPE and subretinal space. So, since the pathogenesis is because of VEGF, the treatment of choice is anti-VEGF injection. In this study, we compared two anti-VEGF drugs. First one is ranibizumab, which inhibits VEGF-A only. Second one is aflibercept, which inhibits VEGF-A, B, and placental growth factor. In ranibizumab, we are comparing two groups, innovator, that is X and Rix, and biosimilar, that is trastuzumab. So what's a biosimilar and why we need a biosimilar? A biosimilar is a copy of innovator drug, but large in size and complex, with similar chemical characteristic, efficacy, and safety. Biosimilar manufacturing is not as complex as that of innovator, so it's comparatively cheaper than innovator drugs. So what are the concerns with innovator drugs? First one is cost. As I told, it's costlier than the biosimilar agents. Then availability. As we know, anti-VEGF is also useful in other common conditions like diabetic edema and all. It's always better to keep some alternative drugs to increase the availability of the drugs. So what's the concern with biosimilar agent? It's the safety. When Rasumab was introduced initially in the market, there were many cases of increased inflammation were reported. So safety is an important factor in concern with the biosimilar agent. Coming to my aim, it's compare efficacy between innovator ranibizumab, biosimilar ranibizumab, and aflibercept in wet ARMD. Study methodology, it's a prospective single-center observational comparative study conducted in a tertiary eye hospital in Kerala. Study duration was 6 months from December 2022 to June 2023. Sample size was 45, 15 in each group. Inclusion criteria, age above 60 years, wet ARMD type 1 and 2 on OCT confirmed by FFA. Media clarity, pupillary dilatation and subject cooperation sufficient for fundus photographs. So, the initial parameters we assessed were vision, fundus examination, OCT and FFA. Then we gave 3 loading doses of monthly injections. Then after in the follow-up visits, we examined vision, fundus examination and OCT only. That means after every monthly injections, that initial 3 months, then from 3 months from the last injection. Coming to my observations and results, comparison of age is almost comparable. That's around 65 to 66 years for all patients. Coming to comparison of vision, here we can see the Logmark score vision in the y-axis. And for the innovator ranibizumab group, initially the vision was worse than other two groups. But initially, after the first injection, for the innovator ranibizumab group, vision improved comparatively better than the other two. But at the end of all injections, the results were almost comparable. For the foveal thickness also, my innovator ranibizumab group had comparatively increased foveal thickness. So that also increased better with the first injection. But at the end of all 3 injections, all were comparable. Coming to pigment epithelial detachment, the innovator ranibizumab had more pigment epithelial detachment patients, and second, the aflibercept. Coming to at the end, we can see coming to the PED flattening effect, the aflibercept group, that is the green color, has almost complete flattening of the flattening effect of the PED. So that worked better for the PED. For the aflibercept worked better. Then comparison of change in SRF, we can see almost comparable for all 3 groups for SRF, and intraretinal fluid also almost all 3 are comparable. For the biosimilar ranibizumab group, we can see there was an increase in the IRF after the second injection, but at the end of 3 injections, all were almost comparable only. So this is the OCT changes, like we can see the fluid and PED. At the end, the vision also improved, and the central foveal thickness also improved. Coming to discussion, innovator ranibizumab is comparable with biosimilar ranibizumab in reference to improvement in vision and foveal thickness. This corresponds with the study by Woos et al. And Ratna D. and Roy K. in Giridhar S. and colleague study. Innovator ranibizumab is comparable with aflibercept in terms of improvement in visual acuity and foveal thickness. It corresponds with the Gills MC and colleague study. Biosimilar ranibizumab is comparable with aflibercept in reference to visual outcome and foveal thickness. Comparing the biosimilar ranibizumab and aflibercept group, I didn't get any study. And coming to my limitations, small sample size, short duration of study, so chances of recurrence could not be studied due to the short duration. And innovator ranibizumab group had more edema. The pre-injection status was more edematous. Conclusion, innovator ranibizumab, biosimilar ranibizumab, and aflibercept were comparable in terms of improvement of vision and foveal thickness and all parameters at the end of all injection. So biosimilar can be used instead of innovator injections with reduced financial burden to the patients and also increase the availability of drugs. And no adverse effects noticed in the biosimilar group in our study. Thank you.
Okay, good presentation.
Thanks.
How did you calculate the sample size in your patients?
Sample size are from the parent study. Using the actually the statistician calculated
the formula and told you that these many were enough for statistical significance.
Is from each group, sir.
Okay, and how did you choose patients into the 3 groups?
Sir, actually, when the patients with wet RMD came, we counseled the patient for the 3 injections. Actually, that financial part was a bit concern for the all patients, but since they had ESI and claims and all, for most of the patients in my study group had these free injections, like due to their ESI claims and all. So
it was like self-chosen.
Self-chosen injections, sir. Yeah.
They went into different groups. Yes, okay. And can you show me, is the presentation on? Okay, I thought in your graphs,
yes,
the blue line was for the biosimilar.
Sir.
To begin with itself, the parameters were lower, the edema was lower, everything was better in that group as compared to the other groups.
Yes, sir. Actually, in the innovator ranibizumab group, it was comparatively the... Yes, sir.
So yes, everywhere you're beginning itself with, them being better than the others.
Sir, vision and this foveal edema was comparatively worse for the innovator group in my study. That was a limitation, as I told you. Thank you, sir.
Shall we call upon the third presenter, Dr. Sulakshana L.
Good afternoon. Thank you, KSOS, for this opportunity. My study topic was outcome of subthreshold micropulse laser in CSER with subfoveal and juxtafoveal leak. As we all know that CSER is a pachychoroid spectrum of disease with unknown etiology. Uh, uh, There is a serous detachment of the neurosensory retina from the retinal pigment epithelium. Earlier, it is thought that the pathophysiology is due to RPE dysfunction. Now it is states that it is due to choroidal dysfunction. Most of the CSER are central leaks, so it is a therapeutic challenge. Juxtafoveal and subfoveal leaks options are limited to photodynamic therapy and pharmacological treatment. The pharmacotherapy is questionable, and the unavailability of PDT, here comes the relevance of our study. The micropulse laser are repetitive shots of bursts that last for microseconds. There is an on time and an off time. The short on time that limits thermal elevation and thermal dissipation to the adjacent tissue, and a long off time that allows the tissue to cool down before the next pulse. The aim of our study is to assess the functional and anatomical outcome following micropulse laser treatment in CSER patients with subfoveal and juxtafoveal leak. It is a retrospective study. The data collected from our EMR, 18 patients who are diagnosed to have CSER in subfoveal and juxtafoveal leak treated with micropulse laser therapy are taken over a period of 2017 to 2023. Our inclusion criteria is duration of symptoms, the presence of SRF in SD-OCT in foveal, perifoveal and juxtafoveal location, and the exclusion criteria is myopia more than 6 diopter, macular disorders. The diagnosis of CSER was confirmed by fluorescent angiography and spectral domain OCT. We studied on the anatomical and functional outcome based on the reduction of central subfoveal thickness, SRF, and visual improvement. These are the data collected pre and post operatively. Based on the guidelines of subthreshold ophthalmic laser society, the titration of the power was done. In our institute, we are using IRIDIS IQ 577 nanometer, and the micropulse laser setting is 5% duty cycle, 500 Hz, zero spacing. Spot size is 100 to 200 micron, and duration is 200 microseconds. And the results are, out of 18 patients, 14 are females, 4 females, 14 males. Age group is between 38 to 78. The visual acuity ranges from 6/6 to CF3 meter. The anatomical outcome of our study is 9 showed complete resolution of SRF post-treatment, and all patients showed significant reduction in central subfoveal thickness. And the functional outcome of our study is 4 patients with 6/6 vision and 6 patients with 6/9 vision. And 16 patients had subfoveal SRF, 1 perifoveal, 1 juxtafoveal SRF. 5 patients had poor visual outcome and showed absence of ellipsoid zone. Our studies shows a statistically significant reduction in SRF and central subfoveal thickness following subthreshold micropulse laser therapy. This is a DFA showing leak in the early phase, that increase in intensity and size after the late phases. This subfoveal SRF pre and post treatment, juxtafoveal SRF pre and post treatment, and this is chronic CSER pre and post treatment. And the discussion is coming to the discussion. In our study, there is a significant reduction in SRF and central subfoveal thickness following micropulse laser treatment were noted. A study by KSOS et al. Showed that 532 nanometer of subthreshold micropulse laser was ineffective in CSER and did not show notable changes in median visual acuity and SDOD parameters. 42% of the patients improved anatomically and visually. In our study, showed that 55% had excellent visual outcome and 42% improved anatomically. And the Luttrell et al. Analyzed the effect of micropulse laser therapy in a small group of 11 cases with the duration of between 1 to 7 months, finding a total resolution of SRF in all cases regardless of the disease duration. Our study also has a similar outcome. The drawback of our study is number of laser sittings and the endpoint of laser are not predictable since it is a subthreshold micropulse laser therapy. In our study, out of 18 patients, 6 need multiple sittings. In chronic CCR, the morphological success of the treatment may not be accompanied by significant improvement in visual acuity. Conclusion is subthreshold micropulse laser is an effective treatment option patients with the CSCR and with the subfoveal and juxtafoveal leak. Anatomical and functional outcome following subthreshold micropulse laser in CCR with was excellent, and the functional result in subthreshold micropulse laser treatment is long-standing CSR are poor. The prolonged presence of SRF lead to retinal thinning and loss of visual acuity. These are my references. Thank you.
Good presentation. See, the thing is, how did you define chronic and acute? When you call chronic CSR?
So more than 6 months, if there is no resolution of subretinal fluid, it is considered as chronic. And acute, if less than 4 months, a resolution of SRF is present.
How long was your study?
Sir, it's a retrospective study.
Okay. And in among all the patients, that 18 patients that you spoke about, did anybody have recurrent CSR?
Yes, sir.
But you not mentioned it there. There's no recurrence in any of the patients who you did the laser?
When these patients did not have any recurrence.
Okay.
Thank you, sir.
Can you follow up on Dr. Leo Soni? And next Dr. Josh will be ready.
Good afternoon to one and all. Today I will be presenting to you an emerging infectious disease of the cornea, macrosporadial keratitis. Despite its clinical significance, it is often misdiagnosed and treated as adenoviral keratitis, leading to suboptimal outcome for the patient. So we aim to explore the clinical features, diagnostic methods, that is simple diagnostic methods possible in our OPD, and we assess the treatment outcome along with clinical distinction from adenoviral keratoconjunctivitis. So we conducted a retrospective analysis in our tertiary center on patients presenting with symptoms of keratoconjunctivitis from 2020 for the next 3 years, and EMR of the patients who were diagnosed earlier with macrosporadial keratitis or adenoviral disease were reviewed. The clinical characteristics and all other duration of symptoms and findings were also documented. We also utilized the corneal scrapings and anterior segment OCT to confirm the diagnosis. Treatment outcome and visual treatment modalities and visual outcomes were also assessed. So among the total 58 patients who presented with keratoconjunctivitis, we had 22 patients who had diagnosed as microsporidiosis as primary diagnosis. There were 10 patients who were treated elsewhere and misdiagnosed as adenoviral disease who presented to our center, and we had documented 26 adenoviral cases in our center. So the peak prevalence of the disease was noticed in rainy season, especially in between the months of June to August. And patients with microsporidiosis also had longer duration of symptoms compared to its adenoviral counterpart. So microsporidiosis patients, they typically had a unilateral ocular involvement presenting as a stuck-on appearance on the cornea due to the presence of spores, and we can see the slit lamp photograph showing the same. So among all the patients, we had 31 patients whose visual acuity was unaffected. Earlier patients were treated with voriconazole, but later, after revised protocol, our patients were given only a symptomatic treatment, which showed favorable outcome with resolution of symptoms and improved visual acuity, thereby bypassing the use of steroids and its harmful side effects. Despite its prevalence, microsporidiosis is being underreported, probably due to the misdiagnosis. The spores of microsporidia can be easily dislodged with a bud, which can be used as a simple OP-based diagnostic method, distinguishing it from adenoviral disease. So we can see the anterior segment OCT of the microsporidiosis patient, where we can see the superficial hyperreflectivity due to the presence of spores. Meanwhile, adenoviral keratitis patients that present with bilateral diffuse punctal epithelial keratitis, subepithelial infiltrate and anterior stromal opacities. Corneal epithelial debridement can be used as a, may help in decreasing the bulk of microsporidia, but no final outcome, there was no major difference. Even no specific drug treatment was, there were many reports of specific drug treatment, but their effects remain controversial. So coming to conclusion, microsporidiosis has typical clinical appearance. Even though it often masquerades as adenoviral keratitis, we can, if there is any doubt, we can use corneal scrapings and anterior segment OCT to diagnose the disease. So increased awareness is necessary about the disease for optimal patient outcome. Thank you.
So the only diagnostic modality that you used was ASOCT, is it? To differentiate between the adenoviral and the microsporidiosis?
Yes, sir. Along with the clinical based technique, we use the cotton bud.
Clinical suspicion as well as ASOCT.
Yes, sir.
Now, the reason why I'm asking this question is because, see, the thing is, you in the ASOCT picture that you showed more of this subepithelial reflectivity, right?
In micro,
adenoviral.
yeah.
In the adenoviral ASOCT, you showed that. But the problem here is that particular ASOCT findings that you're seeing is towards the later part.
Okay.
Understood? No? So you can't use only that as your diagnosis. Did you stain any of these patients?
Yes, sir. Some of the samples were sent for gram stain.
Among them, how many were positive?
Actually, few of them were positive, but the sample size was not adequate in most of them, because they asked for at least 3 slides were necessary.
Yeah. See, because both the diseases are self-limiting. Both are actually self-limiting. Okay. Only if the stroma is involved, then becomes a different thing. But the epithelial variety of both, or most of them, are self-limiting, right? So how do you know which one is which?
In microsporidia, it is basically superficial hyperreflectivity.
Whereas here, it may not be.
It may not be the case. Thanks.
So good afternoon, one and all. My paper is on the topic visual impairment assessment efficacy with electroretinogram in children on vigabatrin, a descriptive study. So vigabatrin is an anti-epileptic drug which is indicated only in refractory seizures in children. But the major ocular adverse effect is retinal toxicity, which is manifested as visual field loss and is estimated to have a prevalence of about 30 to 40%. But for most children on vigabatrin, a normal vision or field assessment is not possible due to their young age or neurodevelopmental delay. So there is a need for an objective test for the detection of the toxicity. So vigabatrin is actually acting at the synapses by inhibiting the enzyme GABA transaminase and thereby increasing the concentration of gamma aminobutyric acid, which is an inhibitory neurotransmitter and producing anti-epileptic effect. So the aim of the study is to analyze the efficacy of assessing retinal toxicity of vigabatrin using ERG in a group of children with epileptic disorders. So this was a retrospective study at a tertiary eye care institute, and patients on vigabatrin presented to our OPD in a time period of 2016 to 23 were included, and we collected the data from the electronic medical records, which included detailed clinical history, functional vision assessment, ocular alignment and movement, cycloplegic refraction, dilated fundus examination, and electroretinograms on baseline visit and at 3 monthly follow-up visits. So the normal vision or visual field assessment is actually not possible in our subjects. So we performed a functional vision assessment. But it is not reliable in detecting the toxicity because it depends upon the general status and cooperation of the patient. So baseline and follow-up ERGs for these patients were done under oral sedation with the syrup chloral hydrate, which is a weight-dependent dosage according to the pediatric prescription and according to the ISCV guidelines in red depot scan with gas field illumination and detailed thread electrodes. Visually worked potentials were also recorded only in the indicated cases. So coming to the results, out of the total 20 study subjects, there were 11 boys and 9 girls with a mean age of 5.4 years. The major study population was below the age of 3 years. The mean duration of the therapy in the study population was 41 months, ranging from 1 month to 9 years. Only 2 study subjects had a longer duration of vigabatrin, more than 5 years. The major indication of the drug was West syndrome or infantile spasm, followed by hypoxic ischemic encephalopathy. In infantile spasm, majority were idiopathic, followed by tuberous sclerosis. So this is the distribution of the baseline functional vision assessment, and we can see that about 70% of the cases had poor functional vision at presentation, which indicate a need for an objective assessment. Moreover, 2 cases developed who had vigabatrin toxicity on follow-up actually showed improvement in functional vision assessment, which is actually contradicting to the effect it produced. So this improvement can be possibly due to better seizure control rather than direct effect on vision. So this is a table which shows the mean B wave amplitude and the oscillatory potential reduction of the values of the light adapted 3.0 flicker 30 Hz. So this is a serial ERG of a patient who had vigabatrin toxicity, and the top trace shows the baseline ERG and the subsequent ERGs on follow-up. So we can see the gross reduction in the B wave amplitude from this picture. So this is a linear plot which shows the percentage reduction of the B wave amplitude from baseline through the follow-up visits in all the 7 patients who had developed toxicity. This is also a linear plot showing the reduction in the oscillatory potentials in the patients who developed vigabatrin toxicity. So in the VEPs recorded in case of suspected optic nerve dysfunction and pallor, the 7 case subjects on dilated fundus examination showed optic nerve pallor, and we recorded abnormal waveforms only in 3 of them, and there was no significant correlation between the VEP and the vigabatrin-induced retinal toxicity. So coming to the discussion, the prevalence of vigabatrin-induced retinal toxicity from our study was 35%, but it is slightly higher than Westall et al., which the study was the largest cohort of children with infantile spasm investigated for vigabatrin toxicity, but it is comparable to Maguire et al., which is a systematic review. So in our study, the percentage reduction in B wave amplitude ranged from 55 to 83%, which was in the range of 37 to 52% in Westall et al., and the average reduction was approximately 69% in our study. The reduction in the amplitude of light adapted 30 Hz flicker cone electrogram ERG is associated with vigabatrin attributed to field loss. So the 30 Hz flicker ERG actually provides an assessment of vigabatrin retinal damage in infants. The oscillatory potential reduction with the vigabatrin treatment was also observed in our study. So there have been studies which showed male predilection, but this was not seen in our study. So coming to the conclusion, vigabatrin has been known to cause retinal toxicity in long-term usage. Hence, assessment in pre-verbal population with a reliable investigative modality is of utmost importance. Our analysis actually indicate ERG as an effective tool for monitoring vigabatrin-induced retinal damage in pre-verbal children. These are my references. Thank you.
Good presentation and good study. Did you do VEP also or only ERG?
VEP only in indicated cases like when we do a dilated fundus examination on those patients who showed optic disc pallor.
Okay. So otherwise, where do you expect the damage in vigabatrin?
Vigabatrin actually causes damages at the level of RP photoreceptors and bipolar cells. So that is the expected theory. So exact mechanism of damage is not still found out. but that is expected.
Do you have studies on in adults to know where the what kind of visual field loss is there?
Yes. It was actually the toxicity of vigabatrin has actually found in a case series of 3 patients who actually showed intense visual field loss after a long duration of vigabatrin therapy, and that is how this visual field loss with vigabatrin has come to.
Okay. Thank you.
Good afternoon. I am presenting a study on foveal avascular zone morphometry and changes with anti-VEGF in patients with non-proliferative diabetic retinopathy with clinically significant macular edema. Diabetic retinopathy, it remains a leading cause of blindness among patients with diabetes. Diabetic retinopathy, a microangiopathy due to chronic hyperglycemia-induced inflammation with release of various inflammatory mediators, the major one being vascular endothelial growth factor. It results in blood-retinal barrier breakdown, causing macular edema and also capillary occlusion. Normal foveal avascular diameter varies between 200 to 600 micrometer. Mean foveal avascular zone area in superficial capillary plexus is 386 micrometer square and in deep capillary plexus is 463 micrometer square. Due to capillary occlusion, a large irregular foveal avascular zone is present in patients with diabetic retinopathy. VEGF being the main inflammatory mediator, intravitreal anti-VEGF, it remains the mainstay of treatment in diabetic macular edema. Though its efforts on diabetic macular edema is well established, its efforts on foveal avascular zone remains controversial. Many discrepancies exist among the studies, some suggesting an increase, others showing a decrease, and also stable foveal avascular zone with variable parameters. In light of these discrepancies, we are doing this study to evaluate changes in foveal avascular zone after anti-VEGF injection and also to find out the changes in best-corrected visual acuity and central subfield thickness after anti-VEGF injection. Ours is a prospective study. It is done in 35 eyes of 43 patients in a tertiary eye care center between January to June 2023. And the patients were evaluated for best-corrected visual acuity using logMAR chart, central subfield thickness by spectral domain OCT, and changes in foveal avascular zone parameters by OCT angiography. The things analyzed in foveal avascular zone were the average diameter of superficial and deep capillary plexus and the foveal avascular zone area in superficial and deep capillary plexus. We have included treatment-naive eyes with non-proliferative diabetic retinopathy with CSME, and we have excluded these patients with other ocular conditions that affect the macular perfusion and those with thromboembolic events within 6 months. Coming to our results, our study showed a statistically significant improvement in best-corrected visual acuity with a mean value of logMAR 0.4 to logMAR 0.2 and a reduction in central subfield thickness from 504 to 391 micrometer. Even though statistically insignificant, our study showed an increase in average diameter of superficial capillary plexus from 823.9 to 825.7 and in deep capillary plexus from 952.9 to 955.2. And foveal avascular zone area also showed an improvement from 551.9 to 553 and deep capillary plexus also showed an improvement from 611 to 612.9. This was also found to be statistically insignificant. Discussion. Thus, our study showed an increase in best-corrected visual acuity and decrease in central subfield thickness with worsening of foveal avascular zone parameters. We have used ranibizumab, which is the commonly used anti-VEGF agent, and we have measured the foveal avascular zone parameters rather than the perfusion density, which were analyzed by the similar studies. Thus, despite restoration of normal retinal architecture with rejection in macular edema, which should show a decrease in foveal avascular zone parameters due to the centripetal movement with resolution of edema, our study showed a slight increase in foveal avascular zone parameters. These were some of the studies which showed decrease in macular perfusion. In a study by El Nahari et al., they found out that the superficial capillary plexus density decreased after injection, and with cessation of injection, the density improved, and again with injection it decreased. In a study by Barash et al., they found an improvement decrease in macular perfusion status 3 minutes following an injection. These were some of the studies which show an increase or stability in foveal avascular zone after injections. Thus, even though statistically insignificant, our study showed that macular perfusion is slightly worsened following single anti-VEGF injection. So, multiple anti-VEGF injections might further worsen macular perfusion, and this improvement in vision could be attributed to the preserved ellipsoid layer and better regaining of inner retinal anatomy due to reversal of disorganization of retinal inner layers and the relief of Muller cell stretch with resolution of the edema. This also signifies that the regain in best corrected visual acuity is not related to the foveal avascular zone perfusion status. From the studies, it appears that the molecular changes that explains worsening of macular perfusion are due to decreased nitric oxide synthesis by endothelial cells and due to the selective knockout of vascular endothelial growth factor in local endothelial cells, which have a prothrombotic effect, and also due to the progressive diabetic retinopathy contributed by other inflammatory mediators other than anti-VEGF. Thus concluding, anti-VEGF injection was found to be effective in improving bus-corrected visual acuity and reducing central subfield thickness, and foveal avascular zone perfusion status worsened following anti-VEGF injection. So long-term follow-up of FVZ is required in patients taking continuous anti-VEGF. So we recommend future studies with larger sample size and longer follow-up to confirm our diagnosis. These are my references. Thank you.
These findings with the visual acuity, is it?
Yes, there was an improvement in visual acuity, but the form. Yes, sir.
So what were the findings that showed you that the FAZ perfusion actually worsened?
Actually, we have taken the average diameter in superficial and deep capillary plexus, and also the area was measured, both in superficial and deep capillary plexus.
There are few other studies showing similar findings.
Studies showing.
Or yours is the only one?
No, similar. There are studies which showed increase in macular perfusion status and also decrease and also stable foveal avascular zone parameters following injections.
The same investigative modality.
Same, both average diameter. We have used OCT angiography because in FFA we can delineate only superficial capillary plexus. In OCT angiography, both superficial and deep capillary plexus can be delineated. Thank you.
Good afternoon. I am going to present paper on choroidal vascular and morphometric changes after intravitreal aflibercept injection in polypoidal choroidal vasculopathy, a retrospective study. Coming to introduction, polypoidal choroidal vasculopathy is one of the commonest exudative maculopathy that we see in our day-to-day practice. It is mainly diagnosis is mainly based on typical clinical findings including reddish orange subretinal nodule and subretinal hemorrhage, and diagnosis can be confirmed by ICGA. In ICGA, we can see branching vascular network of inner choroidal vessels and hyperfluorescence and hypofluorescent halo. Aflibercept is a newer anti-VEGF molecule which act against both VEGFR1 and VEGFR2. Coming to management of PCV. Treatment response of PCV is currently based on demonstration of intraretinal fluid or subretinal fluid reduction on OCT and obliteration of polyps on ICGA. But as ICGA is an invasive procedure, it is not universally available. Recently, new choroidal thickness like subfoveal choroidal thickness and choroidal vascularity index have been described by various authors. Study of the changes in these indices after treatment would be a surrogate for assessing the treatment response. Aim of our study to investigate changes in subfoveal choroidal thickness and choroidal vascularity index after intravitreal aflibercept injection for PCV. Coming to materials and methods, our study was a retrospective study. Study was conducted in a tertiary eye institute in South India. Study period was January 2023 to July 2023. 34 eyes of 33 patients were analyzed in our study. ICGA diagnosed PCV eyes were included in our study. OCT on Heidelberg spectral domain OCT was used for our study. Loading dose of aflibercept standard dose was given in our study. Choroidal changes like subfoveal choroidal thickness and choroidal vascularity index were analyzed in our study. Now, how to measure subfoveal choroidal thickness? For measuring subfoveal choroidal thickness, using a caliper tool, we have analyzed we have taken the vertical distance from the hyperreflective line of retinal pigment epithelium to the reflective layer of choroidoscleral interface. Now, how to measure choroidal vascularity index? For measuring choroidal vascularity index, we have used a software known as ImageJ software. First, OCT image is exported into ImageJ software. Then we have analyzed using the ImageJ software. We have used an algorithm known as NIBLAC algorithm. Using the NIBLAC algorithm, we obtained an 8-bit image. Then this obtained 8-bit image is a binarized image. In binarized image, we can see black and white areas. Black areas represent the luminal area and the white areas represents the stromal area. Then using the formula, using the ImageJ software itself, we obtain stromal choroidal area. Then 100 minus stromal choroidal area, we will get the luminal choroidal area. Choroidal vascularity index is actually total luminal area by total choroidal area. Coming to results of our study, majority of the patients in our study were male. Most of the patients in our study belongs to age group of 71 to 80 years. Most of the patients had one-line improvement. In our study, there was a reduction in subfoveal choroidal thickness from 388.9 to 333.1, which was statistically significant. And choroidal vascularity index also showed a reduction from 63.1 to 61.8, which was also statistically significant. When subfoveal choroidal thickness as treatment biomarker, previous reports demonstrated that subfoveal choroidal thickness decreases significantly after intravitreal injections of ranibizumab and aflibercept, while other studies did not find any significant change after bevacizumab and ranibizumab. However, our study found a significant reduction of subfoveal choroidal thickness after 3 months of treatments of aflibercept. Studies have also shown that aflibercept in comparison to ranibizumab decreased choroidal vascularity index better in neovascular AMD. These studies have excluded PCV, but our study found that PCVs also demonstrate reduction in choroidal vascularity index after aflibercept therapy. There is not enough literature in PCVs treated with aflibercept. Though it was observed that aflibercept was a better agent than ranibizumab in PCV eyes in terms of vision gains and retinal drying, demonstration of choroidal vascular changes have been inadequate in previous studies. Our study demonstrated that aflibercept decreases the choroidal thickness in these pachychoroid eyes by decreasing the dilated choroidal vessels and thereby reducing the intraretinal fluid, subretinal fluid and sub-RP fluid in these patients. When we compare choroidal vascularity index with subfoveal choroidal thickness, choroidal vascularity index is a better parameter because these choroidal vascularity index is not influenced by age, axial length, IOP and time of day. Coming to conclusion, response to aflibercept in PCVIs could be gauged by non-invasive imaging like change in choroidal thickness and change in choroidal vascularity index. Choroidal thickness in PCVI significantly decreased after intravitreal aflibercept injection. Aflibercept treatment also showed decreased choroidal vascularity index changes. These are my references. Thank you.
They received only one injection or multiple injections?
Three injections were given. Monthly 3 injections were given. 3 injections. And 1 month after 3 injections, we were analyzed choroidal vascularity index and subfoveal choroidal thickness.
That you used for the choroidal vascularity, is that a validation method?
There is a using the ImageJ software, we have analyzed.
Was that your new technique or that has been described already?
This is a newer technique. This ImageJ software is used for other binarization of other purposes like, but till now there is no studies available about images software.
You are the first of its kind study.
In using choroidal in Okta, there is studies available using Okta, but using OCT, it is the first study. Thanks.
Vitti and Thomas, please.
So good afternoon. My paper for today is on knowledge, attitude, and practice pattern among ICU nurses on eye care practices in ICU patients. Here are the contents. Eye care forms a major part of care provided to all patients in ICUs. Critical care nurses have limited knowledge about the anatomy and physiology of eyes and ocular manifestations in critically ill patients, which may lead to a delay in the identification and delivery of proper eye care. My objective is to estimate the knowledge, attitude, and practice pattern of nurses regarding the eye care in patients admitted in the ICU in a tertiary care center. A descriptive study was done among the ICU nursing staff with a well-structured questionnaire. My study included 74 nursing staffs. Participants' age, gender, education, experience in critical care, type of ICU, previous eye care training was noted. Data was collected in the form of a questionnaire. Here you can see is the questionnaire. It had 3 sections, knowledge, attitude, and practice, with 7 questions in each section. The questions in knowledge assessment were on different ocular signs. In the patients, their risk factors, management with 2 or more correct responses. A score of 3, 2, 1, or 0 was given respectively according to the response. Participants were again further grouped based on their score into good, average, and poor. Questions on attitude was based on the importance of early detection, treatment, and prevention of eye disease. Positive response is given a score 1 and negative a response of 0. Depending on the total score, attitude was again further graded into good, average, and poor. Now, practice again was assessed based on the method and techniques of eye care practiced by the nurses in the ICU. Response to each practice pattern was again noted, and the participants were graded into good, average, and poor. Statistical analysis was done. And now moving on to the results. 74 of the ICU nurses included in my study. The mean age was 33.7 years. 92 were females. 93% were BSc graduates. 35 of them underwent eye care training. 54% had 1 to 5 years of experience in the ICU. 20.3% were from the neurosurgical ICU. 78.3% of the total study participants had average knowledge. Most of the participants answered that ICU patients were at a higher risk for exposure keratopathy. As you can see in the bar diagram, it's 86.48%. And least knowledge level was for the question on reasons for developing exposure keratopathy, which is 54%. 50% of the study participants had good attitude. Out of the 7 questions on attitude, maximum positive response is for the question the effect of eye care in preventing eye disorders, which is about 90%. And least positive response is for the question on what to be done on seeing a patient with incomplete eyelid closure. There was no significant correlation between the knowledge and attitude score. Majority of the participants had an average practice, that is 54.1%. Maximum response was for the question on last assessment of lid closure, that is 78%, and least response was for the question on the method of cleaning of the eyes of these ICU patients. 66% of the staffs assessed eyelid closure in their last duty. 59.5% of the participants assessed eyelid closure hourly. 37% of the participants instilled eye drops 3 hourly and 6 hourly. 41.9% responded that they had used distilled water to clean the eyes of the ICU patients. 50% of the participants cleaned the eyes hourly. 60% had done eyelid taping for incomplete eyelid closure. And 60.8% of the participants followed a fixed protocol, of which 28.4% of the participants responded saying that they got the protocol from their seniors. Now moving on to the discussion. 93% of the participants were BSc graduates and only 35 had undergone eye care training. Majority of the participants had average knowledge and 50% had good attitude. And majority again showed an average practice pattern. So in our study, we observed that both participants with good knowledge and average knowledge showed a good attitude and an average practice pattern. And there was no correlation between knowledge and attitude score. Now, similar to our study was a study by Khair et al. Now, in contrast to our study, a study done by Mariam et al. Showed a positive correlation with good knowledge and attitude in their study. And another study by Ebedi et al. Showed that the participants had limited knowledge and showed a positive correlation to attitude. Now, majority of the staffs assessed the eyelid closure of their patients in their last duty, and 60% of them reported that taping of eyelids for incomplete lid closure is similar to a study by Aditi Vida et al. In a study by Sonan et al., less than quarter of the nurses responded that they were unaware of the high potential risk of exposure keratopathy, and 50% of the nurses checked eyelid closure and took preventive methods to prevent exposure keratopathy. And an awareness program, along with a protocol-based approach, can improve the knowledge. Now, post our study, an awareness class was held in order to improve the poor knowledge and attitude. And here is a new protocol, which includes grade 0, 1, and 2, along with its treatment approach. Now, here's the conclusion. Ocular complications can occur in a large number of ICU patients due to a lack of awareness, which leads to a delay in the identification and management. A clear protocol can improve the quality of eye care in these patients. Here are the references. Thank you. So it was our hospital, so it's a private, yes sir, private hospital. Yes sir. No sir, the ICU doctor would inform us whenever there's a need of if they found there's any need of any eye related issues, they would call us. That's when we were informed. Not on a regular basis, only when the ICU doctor used to inform us. So some said that they did have an eye care protocol was there, but not everybody had an eye care training. Only few of the staffs had an eye care training, sir. Just 35. So 35, most of them were senior faculties who had 1 to 5 years of experience, sir. Most of them had a lesser experience, like around 1 or 2 years, but most of them who had had higher experience were giving a better treatment, sir. Yes, and drugs. So there was no significant correlation between them. Yes, sir.
Means that even if they knew their attitude was poor, it wasn't.
Yes, sir. If the attitude, if it's good, we can improve the knowledge, sir. But here, if the attitude is poor.
What recommendation would be there after your study?
So in my study, I found that the knowledge was average, but the attitude was good. If the attitude is good, we can definitely give them awareness classes, including with the protocol that I said. We can improve their knowledge. And so, since there was no really bad practice pattern, so the practice patterns can also be improved. Thank you, sir.
Good afternoon. My topic is intraoperative topical antibiotics and avoidance of postoperative BCL reduces the risk of post-C3R infection. Keratoconus is a non-inflammatory corneal ectasia, and collagen cross-linking is a treatment of keratoconus, which increases the mechanical rigidity of the cornea and thus delay or even halt the progression of keratoconus. And corneal cross-linking is considered a relatively safe and effective procedure, but there are certain complications reported associated with it, which includes pain, sterile infiltrates, infectious keratitis, persistent epithelial defect, corneal haze or scarring, corneal edema, and endothelial damage. And infectious keratitis is one of the most concerning complications. Scarring and irregular astigmatism may develop even after the infection control and can cause impairment of vision. The aim of our study was to investigate if avoidance of the BCL postoperatively and use of intraoperative topical antibiotics could reduce the risk of post-C3R infectious keratitis. Ours was a retrospective study in patients with keratoconus who underwent C3R at a tertiary eye institute from January 2020 to December 2021. And the patients were included as two groups, Group 1 comprised of those who were treated with postoperative BCL and intraoperative topical antibiotic was not used. And Group 2 comprised of those who were treated with intraoperative topical antibiotics and postoperative BCL was not used. In the Group 1 patients, initially under topical anesthesia, we debrided the central 7 to 9 millimeter of the corneal epithelium, and thereafter 0.1% riboflavin was instilled every 5 minutes, and UV radiations of 370 nanometer was given at 9 millivolts per centimeter square for 10 minutes while continuing instillation of topical riboflavin, and postoperative BCL was kept, and topical antibiotics and lubricants were given. In the Group 2 patients, under topical anesthesia, initially central 7 to 9 millimeter of the corneal epithelium was debrided, and 0.1% riboflavin was instilled every 5 minutes, and along with that, moxifloxacin eye drops was used intraoperatively every 5 minutes, and UV radiations was given at the same for same duration and at same intensity, while continuing instillation of the topical riboflavin and moxifloxacin eye drops. And postoperatively, BCL was not used, and the same topical antibiotics and lubricants as Group 1 was given. And our study group comprised of 129 eyes of 103 patients, which included 53 males and 60 females, and the mean age group was 24. And Group 1, we studied 46 eyes of 37 patients, and in Group 2, 83 eyes of 66 patients. In postoperative period, 3 eyes out of 129 eyes developed post-C3R infectious keratitis, and the incidence was 6.5%. And all the 3 infections occurred in the Group 1, where we used postoperative BCL, and intraoperative topical antibiotics was not used. And none of the infections occurred in Group 2, where we used intraoperative topical antibiotics and postoperative BCL was not used. And all the 3 infections were bacterial keratitis with an average day of onset of symptoms of 2, and all the 3 were treated with fortified antibiotics, whereas 2 of them resolved with the topical antibiotics, whereas 1 required penetrating keratoplasty. And statistical analysis was done using Fisher's exact t-test, which showed a p-value of 0.043, which was statistically significant. Coming to the discussion, in the study by Rohit Shetty et al., who used standard protocol with the use of postoperative BCL, he reported 4 eyes out of 2,350 eyes developed bacterial keratitis post C3R. And another study by Okay et al., who also used standard protocol with postoperative BCL, he reported a case of post C3R MRSA keratitis. In Samora and Mills reported that patients with polymicrobial keratitis after C3R had history of handling BCL in the immediate postoperative period, and postlated this could be a risk factor for post-C3R infectious keratitis. And Samalis et al. Also found that the use of the BCL and topical steroids prior to the healing of the epithelium is a significant risk factor for microbial keratitis. And in our study, in Group 1, where we used postoperative BCL and did not use intraoperative antibiotics, 3 eyes of 46 developed post-C3R infectious keratitis. Whereas in Group 2, where we used intraoperative topical antibiotics and avoided postoperative BCL, none of the cases developed post-C3R infection. Thus, we concluded that the use of intraoperative topical antibiotics and avoidance of postoperative BCL could significantly reduce the risk of infectious keratitis after collagen cross-linking. These are my references. Thank you.
Very nice study. I have a couple of questions for you. The first question was, how long did you follow these patients? What was your follow-up schedule for these patients?
We follow up the patients in the next day, then first week, and thereafter 1 month, and then for 6 months we follow up the patients.
The second question I had was, there was too much of a difference between Group 1 and Group 2. Meaning it was Group 2 was almost double.
Yes.
So how do you account for that?
Initially, after a couple of cases of infections occurred, our consultants thought of changing the protocol, and I took the time period 1 year before changing the protocol and 1 year after changing the protocol.
The third question is that, how do you prove that your Group 2, the Group 2 is much better than Group 1 then? How did you prove that? Because that is your conclusion.
Yes, sir.
So how do you conclude
Because in the group 2, when we changed the protocol, there was none of the infections. Whereas in the group 1, there was 3 infections in the post cases. Yeah, but the time period was same, sir. 1 year time period was used. That is.
Because you said you followed up first day, then the next day, and then 1 week later.
Yes.
So did you measure the epithelial defect, how it healed and all that?
We checked the epithelial defect. Yes, sir. We looked the cornea, how the epithelium was healing, and most of the patients tolerated it even without the BCL in the group 2.
Why do you want to have it as either or? Why can't you have BCL with antibiotic?
Yeah, that's a drawback of our study. We didn't study each one separatively.
They're given for different reasons. BCL
Yeah.
is given to prevent the
In most of the studies references, BCL was found as a culprit for the post-operative infections. Therefore,
the absence of antibiotic.
yeah, yes, sir.
So
Yeah.
they are given for 2 different reasons. You have 2 totally different ones. You don't have one in between where both could be.
Yeah, we didn't try that, so
Is
we are
there a
looking.
problem of giving moxifloxacin with the BCL in place?
No, sir.